welcome to The Funnel Effect. Today our mission is to explore the terrifying therapeutic tightrope of acute cardiology. We're looking at a realm where the exact same pill that saves your heart muscle can actually cause a fatal hemorrhage in your brain.
Yeah, it's an incredible paradox. You're trying to fix one crisis and potentially triggering another.
Exactly. It's this delicate, literally life or death balancing act of managing blood clotting during a heart attack.
Yeah.
And to find out exactly where that line between salvation and disaster is drawn, we are diving deep into a landmark paper from the New England Journal of Medicine.
Right, from volume 357, number 20.
Yeah, published on November 15, 2007. The source material is titled Prasugrel versus Clopidogrel in Patients with Acute Coronary Syndromes. And the authors of this massive history-making study are Stephen D. Wiviet, Eugene Braunwald, Carolyn H. McCabe, Gilles Montelescott, Witold Ruzillo, Shmuel Gottlieb, Franz Joseph Neumann, Diego Ardacino, Stefano De Servi, Sabina A. Murphy, Jeffrey Riesmeyer, Govindo Wirakoti, C. Michael Gibson, and Elliot M. Antman for the Triton team of 38 investigators.
It is a massive list for a massive undertaking.
It really is. And usually when we talk about a medical diagnosis, there is this comforting expectation of engineering precision. Like if you break your arm, the x-ray shows a jagged white line. Right?
Oh, yeah. The orthopedic surgeon just points at it and says, there it is, let's cast it.
Right. It's super straightforward. But diving into this deep dive, you realize that acute cardiovascular pharmacology is completely different.
It's entirely different. With a bone, it's binary. The bone is broken or the bone is intact. The mechanical problem has a mechanical solution. But stepping into the world of heart medication, well, it shatters that illusion of simplicity.
Yeah, the landscape is incredibly murky. It's fraught with paradox.
Exactly. And the fundamental rule we are confronting today for you listening is that increasing a drug's power to cure almost always intrinsically increases its power to harm.
It's a terrifying trade-off.
It really is. You cannot aggressively manipulate a foundational human biological process, like the blood's evolutionary mandate to coagulate and seal wounds, without inviting severe systemic consequences.
So, to really appreciate the monumental stakes of this trial, we have to thoroughly understand the battlefield first.
Right, and that battlefield is the human heart undergoing an acute coronary syndrome, or ACS.
Right, and for you listening, an acute coronary syndrome isn't just one monolithic event. It's an umbrella term that spans a terrifying, progressive spectrum of oxygen starvation.
Yeah, it has levels of severity.
Exactly. On the milder end, you have unstable angina. This is chest pain that happens unpredictably, even when you're just sitting on the couch resting.
It's basically your heart muscle screaming that its blood supply is critically compromised.
Yeah, and then on the catastrophic far end of the spectrum, you have a full-blown ST elevation myocardial infarction, which doctors call a STEMI.
That's the classic cinematic clutch your chest severe heart attack. A major coronary artery is 100% occluded, and the heart tissue downstream is actively dying by the minute.
Right, but the underlying biological mechanism driving that entire spectrum is essentially identical, right?
Yeah, it just varies in its degree of obstruction. The inciting incident is almost always an atherosclerotic plaque.
Which is basically decades of lifestyle, genetics, and inflammation causing a fatty, cholesterol-rich deposit to build up within the inner wall of a coronary artery.
Exactly. And this plaque isn't just a passive lump of fat. It's a highly active, inflamed microenvironment, and it's covered by a thin, fibrous cap.
And for complex hemodynamic reasons, that cap can fail. It suddenly ruptures or erodes.
Yeah, and when that micro tear occurs, it violently exposes the highly thrombogenic, lipid-rich core of the plaque directly to the flowing bloodstream.
Enter the platelets.
Right. Your blood platelets, which are these tiny, incredibly reactive cell fragments patrolling your circulatory system, they recognize this exposed plaque material as a catastrophic vascular injury.
So their deep evolutionary programming kicks in instantly.
Exactly. They rush to the site of the rupture, adhere tightly to the exposed tissue, and release chemical signals to recruit millions of other platelets. They aggregate together, forming a dense thrombus, a blood clot.
Which, I mean, is brilliant if you're out in the wilderness and you suffer a deep laceration on your leg.
Yeah.
That exact platelet aggregation process is the only thing keeping you from bleeding to death.
Oh, absolutely. It's a survival mechanism.
But inside a coronary artery, which might only be, 3 or 4 millimeters wide to begin with, that evolutionary survival mechanism becomes lethal.
Because the clot aggressively expands and completely blocks the flow of oxygen-rich blood to the heart muscle. That is the acute crisis of an ACS.
Right, so you have a patient rush into the emergency room, the EKG is flashing red, and the clinical clock is ticking down rapidly.
And it's literally equal muscle.
Exactly. And the standard procedure for this, the exact procedure that 99% of the over 13,000 patients in this trial were scheduled to undergo, is called a percutaneous coronary intervention, or PCI.
PCI is the ultimate mechanical solution to a biological crisis.
A specialized interventional cardiologist basically threads a long, thin catheter up through the arterial system, right? Usually starting from the groin or wrist.
Yeah, navigating all the way into the beating heart. They inject a contrast dye to physically see the blockage on an X-ray monitor.
Then they navigate a microscopic guide wire right through the center of the blood clot and inflate a tiny balloon over that wire.
Right. The immense pressure of the balloon physically squashes the ruptured plaque and the obstructing clot outward, embedding it into the artery walls.
And then, to keep the artery from simply collapsing back in on itself, in 94% of the cases in this specific trial, they deploy a stent.
Which is a tiny, intricately engineered, expandable wire mesh tube. It acts as a permanent metallic scaffold to keep the vessel propped open.
Okay, let's unpack this. We're taking a piece of foreign metal and permanently embedding it directly inside an injured human blood vessel.
Yeah, it sounds crazy when you phrase it like that.
I mean, the human body's immune and coagulation systems have to view that stent as a massive, continuous threat.
Oh, the physiological reaction is violent. The body recognizes that metallic surface as foreign and highly dangerous.
So the platelets attack it.
Exactly. The localized platelets desperately want to cover those bare metal struts. They want to form a massive clot right inside the newly opened artery to wall off the invader.
Wow.
And this specific complication is called a stent thrombosis. It is a clinician's worst nightmare.
Because it's not just a gradual re-narrowing, right?
No, it's a sudden, catastrophic, complete occlusion of the stent. It induces a massive, often fatal heart attack instantly.
So the beautiful mechanical solution of a stent is completely useless unless you chemically paralyze the patient's platelets.
Exactly. You have to pair it with a systemic pharmacological solution. And in 2007, as this trial was concluding, the gold standard of care worldwide was dual antiplatelet therapy.
So aspirin and something else.
Right. You give the patient aspirin, which permanently blocks one specific chemical pathway of platelet activation, and you combine it with a second drug from the phenylpyridine class to block a completely different pathway.
At that time, the undisputed heavyweight champion of that class was a drug called Clopidogrel.
Yes. And there is no denying that Clopidogrel was a miracle drug for its era. It saved countless lives.
But reading through the dense background literature of this paper, you realize that the global cardiology community was quietly becoming incredibly frustrated with it.
Very frustrated. It had some major, potentially fatal pharmacological limitations built into its very chemistry.
Right. First and foremost, Clopidogrel is what pharmacologists call a prodrug.
Yeah, and a prodrug is a fascinating chemical workaround, but it comes with a steep physiological cost.
Because when you swallow a Clopidogrel pill, the chemical compound entering your stomach is completely biologically inactive, right?
Exactly. It does absolutely nothing to your circulating platelets in its original raw form. It must travel through the portal vein into your liver, where a highly complex enzyme system has to physically metabolize it.
So the liver has to basically turn the drug on.
Precisely. The liver enzymes have to oxidize the molecule in a two-step process, essentially breaking it down and rearranging its structure to create its active metabolite.
And only then can it travel back out and find its way to the platelets to stop them from clumping.
Right. Only then does it bind to the specific P2Y12 receptor on the platelet surface.
But if a drug requires the liver to physically activate it before it can save your heart, that introduces a massive, unpredictable biological bottleneck.
Absolutely. You are entirely reliant on the patient's individual liver function and their specific genetic makeup to determine if the drug will actually work.
Which sounds incredibly risky in an emergency.
It is. If we connect this to the bigger picture, this metabolic bottleneck is the biological root of interpatient variability. And in a high-stakes emergency room setting, interpatient variability is terrifying.
Because when someone is actively having a heart attack, you need an agent that works predictably and rapidly across the board.
Right. And because of this required liver metabolism, Clopidogrel inherently had a delayed onset of action. It took crucial hours for the active metabolite levels to peak.
Hours you don't have.
Exactly. And even worse, the overall antiplatelet effect it provided was clinically modest. But the most chilling realization for cardiologists was this phenomenon of hyporesponsiveness or clopidogrel resistance.
Meaning some people just didn't respond to the drug at all.
Yeah. We discovered that due to genetic variations in specific liver enzymes, particularly an allele known as CYP2C19, up to 30% of the population simply could not metabolize the prodrug efficiently.
Like 30%, that's a huge portion of patients.
It is. These patients were clinically exposed, they were following their doctor's orders perfectly, taking the standard dose every single day, and yet their bodies were failing to produce enough of the active metabolite.
So they were suffering from recurrent atherothrombotic events, new heart attacks, or lethal stent thrombosis, right under the nose of their medical team.
Yes. Finding a faster, vastly more potent, and more genetically consistent drug was the holy grail of acute cardiology at that moment.
You know, I think about it like this. Imagine Clopidogrel is a security guard you've hired to stand at the entrance of a volatile coronary artery to stop dangerous platelets from clumping together and causing a riot.
Okay, I like that analogy.
But because this particular security guard has a very sluggish internal metabolism, he takes hours to wake up, drink his coffee, and actually get to his post. By the time he arrives, the riot might have already started.
Exactly. The damage is done.
And even when he is physically standing there because of his genetics, he sometimes falls asleep on the job. He just doesn't show up with enough energy to hold back the crowd. Dangerous clots just sneak right past him while he's dozing.
That perfectly captures the clinical frustration. The cardiologists look at the data and realize the security guard was fundamentally unreliable. They desperately needed to recruit a much better candidate.
Which drives the development of the new candidate, Prasugrel.
Right, Prasugrel. From a chemical standpoint, Prasugrel is also a novel thienopyridine prodrug, and it targets the exact same P2Y12 receptor on the platelets that Clopidogrel does.
But it's structurally different.
Yes, its molecular structure was specifically engineered to be metabolized vastly more efficiently by the body. It completely bypasses the complex, multi-step cytochrome P450 bottleneck that hindered Clopidogrel.
So it wakes up faster.
Much faster. In early phase 2 testing, the results were astonishing. Prasugrel was shown to inhibit platelet aggregation much more rapidly, far more consistently across diverse patient genetics, and to a significantly greater overall extent than even double or triple doses of Clopidogrel.
It was a molecular powerhouse. But wait, how do you definitively prove to the global medical establishment that this new, highly efficient security guard is actually better at saving lives in the real world?
You build a massive trial.
Right. You don't just guess based on early testing. You have to build a rigorously controlled global clinical trial. And that is exactly what the Triton-TIMI 38 trial was designed to do.
The scale of it is incredible.
It's mind-boggling. We're talking about enrolling exactly 13,608 human beings who are actively experiencing acute cardiac emergencies.
Yeah, from 707 independent medical sites?
Across 30 different countries worldwide, all meticulously enrolled and monitored between November 2004 and January 2007. Imagine the logistical nightmare of that.
Oh, it's immense. You have emergency rooms in 30 different countries, doctors speaking different languages, all trying to standardize a complex drug protocol in the chaotic minutes, while a patient's heart muscle is actively dying.
Heroic is the right word. How did they structure such a massive population?
They divided the patients into 2 distinct clinical cohorts based on the specific severity and presentation of their heart attack. They enrolled 10,074 patients in the moderate to high-risk unstable angina or NSTEMI cohort.
And these are serious, life-threatening events.
Absolutely. And to ensure they were capturing truly high-risk patients, they used strict inclusion criteria. For example, patients had to have a TIMI risk score of 3 or more.
What exactly goes into that TIMI risk score?
It's a validated clinical tool. It assigns points for factors like age over 65, the presence of specific EKG changes, elevated cardiac enzymes in the blood indicating active muscle death, and a known history of severe coronary stenosis.
So a score of 3 or more meant these patients were highly vulnerable to dying or having another heart attack.
Exactly. And then, as the second cohort, they enrolled 3,534 patients with STEMI, representing the most acute, immediate, fully blocked artery heart attacks.
And the ultimate test was head-to-head combat. Half the patients randomly got the new experimental drug, Prasugrel.
Right. They started with a heavy 60 milligram loading dose right around the time of their catheter procedure to shock the system. That was followed by a 10 milligram daily maintenance dose for 6 to 15 months.
And the other half got the prevailing standard of care, the FDA-approved regimen of Clopidogrel, a 300 milligram loading dose, followed by a 75 milligram daily maintenance pill for that same time period.
But what is incredibly crucial to understand about the profound rigor of this trial design is the precise timing of the medication administration.
How so?
Well, about 25% of the patients received their blinded study drug before the interventional cardiologist even placed the first guide wire into their coronary artery.
Okay.
And the vast majority, 74%, received the drug while they were actively on the table during the PCI procedure itself or within 1 hour after leaving the cath lab.
So they're getting it fast.
Yes, but here is the critical defining detail for the unstable angina and NSTEMI patients. The trial protocol dictated that the doctors absolutely had to visualize and know the patient's specific coronary anatomy via an angiogram before they randomized them.
Wait, okay, I'm stuck here.
Yep.
If the patient is actively having a severe heart problem, and we know that early platelet inhibition saves heart muscle, why are we delaying the administration of the drug until we visualize their anatomy on a screen?
It's a great question.
Because waiting just feels entirely counterintuitive to saving a dying heart. Why not just give them blood thinner the second they get into the ambulance?
Because the trial designers had to anticipate the horrific risk of emergency coronary artery bypass grafting, or CABG surgery.
Open heart surgery.
Exactly. Consider the clinical reality. You have a patient with severe chest pain. If you give them a massive, irreversible loading dose of a profoundly powerful antiplatelet drug in the ambulance, you've committed them to that pharmacology. And then you get them to the lab, shoot the dye, and discover that their blockages are incredibly complex. Perhaps all 3 major vessels are heavily calcified and diseased, making a simple percutaneous stent completely impossible.
Oh, wow. So they need their chest cracked open immediately.
Yes, that patient urgently needs emergency open heart bypass surgery. And if you have just loaded their system with Prasugrel, you are sending a patient into major cardiovascular surgery whose blood is pharmacologically incapable of forming a clot.
They would literally bleed to death on the operating table.
Precisely. The surgeons would not be able to achieve hemostasis. By mandating that the anatomy be deemed suitable for a percutaneous stent first, the trial investigators carefully protected the patients from that specific lethal surgical danger.
That makes total sense now. It is a brilliant testament to how meticulously this trial was designed to mirror real-world safety.
It really prioritized rigorous clinical practice over just chasing blind efficacy.
But looking at the sheer volume of data, I have to push back on the massive sample size. I look at that number, 13,608 patients, and I have to ask, why do we need that many human beings for a drug trial?
It seems excessive, right?
Yeah. I mean, if a chemical compound works and stops platelets from clumping, shouldn't you be able to definitively prove that after testing it on 500 people? Or maybe 1,000 at most. Why coordinate across 30 different international health systems?
It fundamentally comes down to the mathematics of statistical power and the extreme rarity of the specific catastrophic events they were trying to prevent.
Like the stent thrombosis.
Exactly. Remember that concept of stent thrombosis, the sudden catastrophic clotting of the metal stent itself? In the Clopidogrel era, with standard therapy, that horrific event was only occurring in about 1 to 2% of patients overall.
Okay, so it's relatively rare.
Very rare. Now imagine if you only test your new drug on 500 people. A 1% event rate means you might see a stent thrombosis happen just 5 times in the control group. If the new drug is effective and drops that rate to 2 times, the absolute difference you are observing is just 3 individual people.
Which isn't a lot.
It's nothing. From a mathematical standpoint, that could easily just be random background noise. A coin flipping heads 3 extra times by pure chance.
So you can't build medical guidelines on that.
You absolutely cannot change global medical guidelines, abandon a drug that is currently working for millions, and introduce a highly potent new chemical based on a statistical coin flip.
So you need a massive pool of people to prove it's a real trend.
Exactly. To definitively prove that a new drug reduces a lethal event from 2% down to 1%, and that it's a biological reality, not a statistical fluke, you require an enormous sample size.
The trial statisticians calculated in advance that they needed at least 875 primary endpoint events to occur across the trial to achieve 90% statistical power.
And to guarantee you witness 875 rare events, you have to enroll thousands and thousands of highly monitored patients.
Wow. Well, with the stage perfectly set, the massive trial running smoothly across the globe, and the mountain of data finally rolling in, we arrive at the moment of truth.
The efficacy endpoints.
Exactly. the central question of the trial. Does Prasugrel actually stop the clots better than the reigning champion, Clopidogrel?
And the answer, unequivocally, was yes. It was an absolute pharmacological triumph.
The raw data on efficacy is incredibly striking.
Yeah.
The primary efficacy endpoint of this trial was what they call a composite endpoint, right?
Yeah. In cardiology trials, because individual catastrophic events like death or stroke can be relatively rare, researchers group the most critical outcomes together to measure the overall protective effect of the drug.
So the composite here was the combined rate of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke.
Correct. And in the Clopidogrel group, representing the best standard care of 2007, 12.1% of patients experienced one of these devastating primary events.
But in the experimental Prasugrel group, that number dropped significantly to 9.9%.
Which generates a hazard ratio of 0.81. That translates to a highly statistically significant 19% relative risk reduction.
A 19% relative risk reduction across a population of thousands of high-risk cardiac patients is massive.
It translates to countless actual human lives saved and permanent disabilities prevented.
And when you break down the specific components of that composite endpoint, the individual victories of Prasugrel become even clearer. The rate of recurrent myocardial infarction dropped from 9.7% on Clopidogrel down to 7.4% on Prasugrel.
That's a huge drop in second heart attacks.
Yeah, and the need for urgent target vessel revascularization, which basically means the patient is crashing, the artery is closing up again, and you have to rush them back into the cath lab, that dropped from 3.7% down to 2.5%.
What's fascinating here, and what truly sent shockwaves through the interventional cardiology community, is the specific targeted data on stent thrombosis.
This is the ultimate test, right?
Yes. It's the unforgiving test of the drug's raw potency at the precise microscopic site of the metal implant. The rate of definite or probable stent thrombosis plummeted from 2.4% in the Clopidogrel group down to just 1.1% in the Prasugrel group.
That is a massive 52% relative reduction.
Cutting the risk of a catastrophic, sudden stent clot in half is a monumental clinical achievement. It conclusively proved that the drug was absolutely dominating at the exact biological site of maximum danger it was designed to target.
And it wasn't just how well it worked overall, it was how incredibly fast it exerted its power.
Yeah, the onset speed is critical.
The published paper includes these visual graphs called Kaplan-Meier curves, which track the percentage of patients who remain free of an event over time.
If you visualize a Kaplan-Meier curve, it looks like a staircase slowly trending downward as time goes on and adverse events naturally happen to the patient population.
Right. And by day 3 of the trial, just 72 hours after the initial emergency procedure, the staircases for the two drugs have already separated significantly.
It's visually very striking.
5.6% of the Clopidogrel group had already suffered a primary event, compared to only 4.7% of the Prasugrel group. That mathematically proves Prasugrel's rapid onset of action.
It gets to work immediately, entirely bypassing that sluggish liver bottleneck.
And when you follow the chart outward, those curves continue to diverge steadily all the way out to 15 months. It proves it has sustained long-term maintenance power too.
Precisely. From a purely mechanistic standpoint, Prasugrel brilliantly solved both of Clopidogrel's major pharmacological flaws.
It hit hard and fast in the acute phase, and it held strong for over a year to prevent late-stage stent thrombosis.
Exactly.
Here's where it gets really interesting, though.
Oh, I know where you're going with this.
If you are a scientist sitting on an independent data safety monitoring board, reviewing this unblinded data as it comes in, and you clearly see that Prasugrel is absolutely wiping the floor with Clopidogrel on efficacy, shouldn't they have just stopped the trial immediately?
It's a common ethical question in trials like this.
Right. Why ethically keep giving half the enrolled patients the clearly inferior drug? Why is there a catch to this miracle data?
Because human biology is an unforgiving zero-sum game. You absolutely cannot aggressively inhibit the blood's fundamental life-saving ability to clot without simultaneously, unavoidably increasing the risk that the patient will bleed inappropriately.
And the researchers knew this.
They fundamentally understood this pharmacological reality. That's exactly why the trial wasn't just blindly cheering for efficacy, it was meticulously tracking safety parameters.
Because the mechanism is identical.
Exactly. The profound reality is that the very chemical mechanism that prevents a lethal clot from forming around a stent is the exact same chemical mechanism that prevents a life-saving clot from forming if you happen to develop a bleeding ulcer in your stomach.
Or if a microscopic vessel bursts in your brain.
Right. You cannot separate the two effects.
So if Prasugrel is this incredibly efficient fire hose that stops clots in their tracks,
Yeah.
you can't just unleash that kind of biological force without expecting severe collateral damage.
And that brings us to the dark side of the data, the ultimate clinical cost of that pharmacological potency.
Right. We just spent 20 minutes lauding the primary efficacy endpoints. Now we have to flip the coin and look at the key safety endpoint. TMI major bleeding that is not related to a bypass surgery.
And here, the hard numbers tell a deeply sobering story about therapeutic trade-offs. A TMI major bleed is not a minor nosebleed or a bruise on your arm.
It's serious.
Very. It is defined as a clinically overt bleeding event that causes a massive drop in the patient's hemoglobin levels, or any bleeding that occurs directly inside the skull.
And major bleeding of this severe nature occurred in 1.8% of the patients taking Clopidogrel. But in the patients taking the highly potent Prasugrel, that complication rate jumped to 2.4%.
Which generates a hazard ratio of 1.32. That clearly translates to a highly statistically significant 32% relative increase in major bleeding events.
Wait, a 32% relative increase in severe spontaneous bleeding. How on earth does a doctor rationalize that?
It gets harder when you look at the specific severity.
Yeah, because we aren't just talking about a little extra blood loss. Life-threatening bleeding that requires massive transfusions or immediate surgical intervention to save the patient's life, was 1.4% on Prasugrel compared to just 0.9% on Clopidogrel.
And then there's the most tragic, devastating metric of all, fatal bleeding.
Spontaneous bleeding that directly caused the death of the patient in the trial. That catastrophic event occurred in 0.1% of the Clopidogrel patients, but it quadrupled to 0.4% in the Prasugrel patients.
It's a stark reality. Furthermore, we have to look closely at what happened to the small fraction of patients who ended up requiring emergency open-heart CABG surgery while they were heavily loaded with these daily drugs.
Right, the ones whose disease progressed.
Exactly. For those highly vulnerable surgical patients, major bleeding complications were drastically higher on Prasugrel, a staggering 13.4% compared to a much more manageable 3.2% on Clopidogrel.
Wow, so the surgeons just couldn't stop the bleeding.
They couldn't. It is a vivid, real-world demonstration of just how profound and irreversible the platelet inhibition from Prasugrel really was.
You know, I think about it conceptually like fighting a massive raging house fire.
Go on.
Clopidogrel is like showing up with the standard garden hose. You point it at the fire, which represents the blood clot in the artery, and because the pressure is low, it might not put the fire out fast enough.
Right, the house might burn down.
Yeah, the heart attack progresses, but it's relatively safe. The water won't ruin your living room furniture. Prasugrel, on the other hand, is a specialized industrial high-pressure fire hose.
It'll definitely put out the fire.
It will absolutely blast the fire out, but the sheer aggressive kinetic force of that water volume is going to cause immense structural damage to the house. It's going to blow out the windows, rip the drywall off the studs, and flood the basement.
And that structural water damage is the bleeding? That is an exceptionally accurate analogy. This raises an important question for the practicing clinicians reading this trial data. How do you intellectually and ethically weigh the devastating risk of the fire against the inevitable structural water damage?
How did the authors handle it?
They recognized this immense dilemma, and they broke this clinical trade-off down into a very tangible, easily digestible metric.
What was the math?
They calculated that for every 1,000 patients treated with Prasugrel instead of Clopidogrel, the high potency of the drug successfully prevented exactly 23 myocardial infarctions.
Okay, that's a lot of heart saved.
However, that magnificent life-saving benefit came at the exact unavoidable cost of causing 6 extra major life-threatening hemorrhages.
23 actual heart attacks stopped, but 6 severe major bleeds actively created.
Exactly.
Okay, I have to admit I'm spinning a bit here. What does a doctor actually do with that terrifying math?
It's a heavy burden.
If Prasugrel gives with one hand and violently takes with the other, causing severe fatal bleeds in a few shares, how do doctors possibly know who to actually prescribe this drug to without feeling like they are playing Russian roulette?
Well, the researchers didn't just throw their hands up in defeat and publish a confusing paper. They dug incredibly deep into the statistical data to find out exactly who was experiencing the miraculous benefits and who was actively paying the ultimate price.
So they look for subgroups.
Yes. To navigate that complex ethical and clinical dilemma, the researchers utilized an analytical concept called net clinical benefit.
And what does that entail?
It takes all the good clinical outcomes, the prevention of death, the reduction in MIs, and the prevention of strokes, and mathematically weighs them directly against the bad clinical outcomes, the life-threatening and major bleeding events.
They basically put all the human suffering on a single scale.
Exactly. And when they ran this complex calculation for the entire 13,000 patient trial cohort as a single group, Prasugrel still emerged victorious overall.
So overall, the good outweighed the bad.
Right. The total adverse event rate was 12.2% for Prasugrel versus a higher 13.9% for Clopidogrel. The net clinical benefit across the general population was decidedly positive.
But there's a catch, isn't there?
A massive practice-changing catch. When the statisticians conducted post-hoc exploratory subgroup analyses, meaning they sliced the population into specific demographic and clinical groups, they discovered that this benefit was absolutely not distributed evenly.
Right. They found 3 very specific, highly vulnerable subgroups of patients who raise massive flashing red flags in the data.
3 distinct groups of people who basically should almost never get this new drug.
Let's break those groups down in detail because this is where the nuance is critical. First, they looked at patients who had a known medical history of a prior stroke or a transient ischemic attack, often called a TIA.
Which is essentially a mini stroke that resolves quickly.
Right. And for these specific patients, Prasugrel didn't just fail to provide a net positive benefit, it actively caused massive net harm.
And in the context of clinical pharmacology, net harm is an absolute disaster. In this specific subgroup of patients with a neurological history, Prasugrel actively caused significantly more intracranial hemorrhages.
Which is bleeding directly into the fragile tissue of the brain.
Yes. There were 6 documented cases of catastrophic intracranial hemorrhage in the Prasugrel group for patients with a prior stroke, compared to absolutely 0 cases in the Clopidogrel group.
Why did this happen?
Because a patient who has already survived a prior stroke has inherently compromised, damaged, and highly fragile vasculature within their brain. The structural integrity of those microscopic vessels is permanently weakened.
So when you introduce a high-pressure fire hose antiplatelet agent like Prasugrel into that specific environment,
Those weakened vessels simply cannot hold up against the intense pharmacological pressure. They spontaneously rupture, the patient bleeds into their skull.
the second glaring red flag group was the elderly population, specifically defined in this trial as patients aged 75 years or older.
Right, and for them, the data showed absolutely 0 net clinical benefit.
So the significantly increased risk of severe bleeding in these older patients completely, perfectly canceled out the drug's incredible power to prevent recurrent heart attacks.
Exactly. And the third red flag group was people with a very low baseline body weight, specifically those weighing less than 60 kilograms, which is roughly 132 pounds.
And again, for this lightweight group, there was 0 net clinical benefit observed. Why is that?
The underlying physiological reasoning here is actually quite logical if you think deeply about pharmacokinetics, how the body absorbs, distributes, and clears a chemical compound.
Okay, walk us through it.
For the elderly population, their liver and kidney metabolic clearance rates are naturally much slower due to aging, and their systemic blood vessels are inherently more friable and prone to rupture.
And for the low body weight group?
For patients with a significantly low body weight, giving them the exact same standard 60 milligram heavy loading dose and 10 milligram daily maintenance dose that you give to a 200-pound patient might have essentially resulted in an accidental systemic overdose.
Because their blood volume is just smaller.
Exactly. Their much smaller total blood volume and body mass simply accumulated vastly excessive concentrations of the active metabolite. It pushed their overall platelet inhibition past the intended point of cardiovascular safety and deep into the territory of active spontaneous bleeding danger.
So if you are a doctor and you look at this data, the path becomes clear through exclusion.
It does.
If you actively choose not to prescribe Prasugrel to the prior stroke patients, to the elderly over 75, and to the low body weight patients, what happens to the efficacy data for everyone else left in the trial?
The results for that remaining core group are absolutely spectacular.
Really?
Oh, yeah. For the patients without those 3 specific clinical risk factors, Prasugrel demonstrated massive, undeniable efficacy, a highly favorable and robust net clinical benefit, and crucially, absolutely no statistically significant difference in the rate of major bleeding when compared to Clopidogrel.
Wow. It's a stunning validation of the drug's core design.
It essentially proves that Prasugrel is an incredible, life-saving molecular tool, provided the physician is incredibly diligent about giving it to the right physiological candidate.
Now, I want to touch on one deeply bizarre anomaly hidden in the safety data, because it really underscores how profoundly these powerful drugs affect the entire human biological system.
I know exactly what anomaly you're talking about.
The data tables showed that colonic neoplasms, which are essentially hidden tumors growing in the colon, were actually diagnosed significantly more frequently in the patients taking Prasugrel.
Yeah, there were 13 new cancer diagnoses on Prasugrel versus only 4 in the Clopidogrel group.
So what does this all mean? The drug causes cancer.
Absolutely not. We must be biologically precise here. Prasugrel absolutely does not cause cancer. It is biologically impossible for a platelet-inhibiting compound to induce a complex cellular tumor in a matter of mere months.
So what's happening?
What the data is actually capturing here is a deeply complex phenomenon known in pharmacology as an unmasking effect.
An unmasking effect. So it accidentally highlights a pre-existing cancer. It's like turning on a massive blinding floodlight in a dark, messy room because you're desperately trying to find your lost car keys, and in the harsh glare of the light, you accidentally spot a massive termite infestation in the corner of the wall.
That floodlight analogy is perfect.
The floodlight didn't cause the termites to suddenly exist, but the intensity of the light forced you to see them and deal with them immediately. So Prasugrel didn't cause the colon tumor. The spontaneous bleeding was just the loud alarm bell.
Precisely. These specific trial patients already had hidden entirely asymptomatic, undiagnosed tumors silently growing in their gastrointestinal tracts long before they ever enrolled in the trial.
And tumors have messy blood supplies, right?
Yes. Tumors, by their very nature, are highly vascular. They rapidly generate their own messy, incredibly fragile, and poorly constructed blood supply to feed their growth.
So when you introduce Prasugrel,
When you introduce a profoundly potent antiplatelet agent like Prasugrel into the systemic circulation, those fragile, poorly formed tumor vessels simply cannot maintain their integrity. They spontaneously start to bleed.
and that sudden, noticeable gastrointestinal bleeding brings the terrified patient to the immediate attention of a doctor.
Right. The medical team performs a colonoscopy specifically to find the source of the mysterious cancer.
That is wild.
We see this exact same unmasking phenomenon frequently with other strong systemic blood thinners like warfarin. The drug precipitates a complication that inadvertently leads to a primary diagnosis.
I have to ask you, addressing the listener directly here, think about the wild ethical and medical paradox of that specific scenario.
The deep one.
If a drug causes you to bleed internally, which is a terrifying adverse event, but the underlying reason you are bleeding is because the drug just accidentally highlighted a silent, undiagnosed, potentially lethal tumor in your colon, is that bleeding complication actually a bad thing?
Right. Or did it save your life?
Exactly. Did that drug inadvertently act as an accidental, life-saving early warning system? You suffer a terrifying drug complication, but it might lead directly to catching a fatal cancer early enough to actually treat it with surgery.
It perfectly, almost poetically, encapsulates the dual, inseparable nature of these highly potent systemic therapeutics. Every single pharmacological action you take to alter a fundamental biological pathway has a profound, sometimes entirely unexpected, systemic reaction across the entire organism.
So as we wrap up this incredibly deep journey, we step back and look at the Triton-Timothy 38 trial in its immense totality.
It was an epic, global scientific undertaking.
It definitively proved Prasugrel is an absolute triumph of targeted pharmacological engineering. It brilliantly bypasses the liver's genetic bottlenecks, it acts incredibly fast in the critical acute phase, and it shuts down platelet aggregation with astonishing, undeniable power.
It does exactly what it was molecularly designed to do, much, much better than its predecessor, Clopidogrel.
And it practically eradicated the terrifying fear of early lethal stent thrombosis for interventional cardiologists.
But the true lasting legacy of this massive paper is the intense clinical nuance it permanently forced upon the global cardiology community.
The sledgehammer versus the scalpel.
Exactly. It proved definitively that in the high-stakes realm of cardiovascular medicine, a massive pharmacological sledgehammer is not always intrinsically better than a careful scalpel.
You absolutely cannot just blindly apply maximum molecular power to every single patient who walks through the doors.
You have to meticulously evaluate the individual human being. Their age, their exact body weight, their specific nuanced medical history.
And deliberately match the potency of the pharmacological tool to the specific biological reality of the fragile patient sitting right in front of you.
Well said.
Which leaves us with a final, deeply provocative thought for you to ponder. Imagine for a moment that you are the attending ER doctor. A patient comes violently rushing through the double doors at 2 a.m., actively having a massive, life-threatening STEMI heart attack.
They're in agonizing pain.
Exactly. They are in agonizing, crushing pain. The cardiac monitor is screaming in red. You know you have only minutes to save their heart muscle from permanent, irreversible cell death.
The pressure is immense.
In that chaotic moment, you do not have time to weigh them carefully on a perfectly calibrated scale. You do not have time to dig through 10 years of fragmented, complex medical records to see if they perhaps had a minor TIA mini-stroke a decade ago.
And you certainly don't have time to run complex statistical risk algorithms.
You have to make a choice right then and there about which drug to push into their 4V. How do we as a society build coherent medical guidelines that reconcile the messy, panicked, utterly chaotic reality of a 2.0 a.m. emergency room with the pristine, controlled, highly filtered statistical precision of a 15-month, 13,000-person international clinical trial?
That massive, seemingly unbridgeable gap between clean data and messy reality is the real, terrifying challenge of translating pure science into human survival.
Thank you for watching The Funnel Effect.